So I actually had a close family member who was an independent pharmacist and he owned his own pharmacy. And I worked there in high school. And then once I got into pharmacy school, I had no idea about all of the different specialties of pharmacy and clinical pharmacy. And I saw my professors at UC, they would come in and teach classes and then they would go and work in the hospital. And it just kind of opened my mind to we could be clinical specialists in the hospital rounding with the doctors making decisions at the bedside, and that was something that I wanted to be a part of. So there are two different types of models in clinical pharmacy. I don't know if they've told you about this, and I don't think I really knew before I got out into residency. But so there's a clinical specialist model at a hospital where clinical specialists will work in their specialty and kind of have their own floor, whether it's an ICU or internal medicine or cardiology, and they'll be on that floor, do their work, and kind of go home for the day. I am working at kind of a split model where I specialize in emergency medicine. I also work in internal medicine sometimes. And then 1 week out of every month, all of the pharmacists will go down and use that time for their staffing in the central inpatient pharmacy. So it's not 1 week. It's not the same week for everyone, but everyone has at least 1 week per month just down in the pharmacy working, dispensing, verifying.
Yeah, I guess it's pretty cool because it keeps the job kind of like dynamic. You're not in the same place doing the same thing. So it's a nice brisk change of pace, I'd say.
Yeah, definitely. And me working in emergency medicine, I need to make sure that I know the quickest way to get that medication to the bedside up in the ED.
Exactly.
So working down in the pharmacy 1 week per month helps me know the function of the pharmacy and where to get those medications quicker.
Wait, so jumping off of that point really quickly.
Yeah, sure.
Do you work with patients who get admitted into the ER, whereas they actually give you a call right then and there and they tell you, do you have this type of drug because we need it for this type of patient because this situation actually happened right now, and you have to like think on your feet and get moving so they can like get the drug as soon as possible?
Right. So they don't actually give us a phone call. In the emergency department, we have a desk right there, and they will have a overhead announcement saying emergency medical services on the telephone, and we will go to the provider's desk with them, get the call from EMS saying they're bringing in someone, cardiac arrest, stroke alert, a trauma, and we will go into the bedside whenever EMS brings the patient in, and we'll help make decisions with the medications and draw them up right there. I think having more information and being able to make a good decision about a specific medication. I think I could work retail, but the limited information you have about the patient to make a good clinical judgment scares me. And oftentimes it's difficult to get a hold of providers if you have questions. Right now, everyone is stressed and there's a high workload for everyone. So I think working in the hospital, having that information is the most beneficial and appealing to me. Since we aren't a clinical specialist model, balancing the different specialties and kind of turning your brain on to internal medicine versus emergency medicine. I know some people at my hospital will work like ID specifically and then have to go over to cardiology, and changing that mindset based on what the providers want from you and need from you at the time can be challenging. I feel like I have so many. I swear, being at the bedside in the emergency department and being able to make those clinical decisions, having access to the Omni-cells, so you have medications right there at the bedside, and you can pull them up and make sure that you're giving the appropriate dose, especially because we also respond to pediatric patients. Any trauma that comes in the door, whether it's adult or pediatric or cardiac arrest that comes in the door, adult or pediatric, we're there. And so being able to make sure we're getting the appropriate doses when the nurses might be stressed or scared if they're newer and not comfortable with pediatric patients, or maybe we have resident physicians who are there and not comfortable with pediatric patients, we're there to kind of ground them and make them know that it's okay. We're doing the right thing. We have the right dose. We're there for you, whatever you need.
Yeah. So now that you say that you're there bedside, can you
Mhm.
actually like see their progress, or like as they get better and better? Because that would be a pretty rewarding experience. Or do you just like give the dosage, approve the medication, and then they can like slowly with other physicians they can like study their progress? Or do you actually get to see them be better and get up and stand out of bed?
Right. So it depends on the patient. It depends on what they're coming in for.
Okay.
If maybe they came in for a seizure and we were able to break the seizure and control it, and they are able to be more stable and calm, that's really rewarding.
Okay.
If it's like a cardiac arrest patient and we're able to get them to ROSC, that return of spontaneous circulation, maybe stabilize them, get their heart rate and heartbeat back. We'll send them up to the ICU to recover. And so they're getting the best care they can in the ICU afterwards. And we'll hear from our colleagues and say, hey, that one that came in, they're going home today. And that's
Yeah.
really rewarding to hear. I think the emotional aspect of some of the events that come in are really difficult, especially for younger patients who come in. I think just compartmentalizing the emotional
Yeah.
side of it and their age and maybe what their past medical history is, if you know that and know how much they've struggled, compartmentalizing that from you doing your job right now and trying to take care of them in the best way possible.
Because
I
we're
think that's the
human.
hardest
Yeah.
part. So my motivation, I think, is to help the next level of learners. We have students, we have interns, we have first year residents, and we have a second year critical care resident. And I just want to make sure that I'm giving them the best information possible and the best tools they can have to make those clinical decisions. I know when I was at UC, we didn't have the emergency medicine electives class. I don't know if you guys have it now, but it was there before I started. And
Okay.
so, and I didn't have it where I did residency either. So just giving that exposure to the students and interns and first year residents so they can decide if maybe emergency medicine is something they want to do, or if it's not, maybe the things that we see in the emergency department can help them in their specialty wherever they go.
Yep.
Future goal. Well, I want to be specialized in emergency medicine. It isn't released yet with BPS, but it's coming. I would like to do that. And then just continue to be a preceptor and better myself to make sure I'm giving those students and learners the best possible tools. So keep your mind open, stay
Okay.
curious. I actually had that advice from Dr. Lucas when I was on her rotation. When I rounded up, she told me to stay curious, and I pass that on to all of my learners that I see. You might think you know something, but information is constantly being updated. So don't, yeah, I know it's a struggle. It's tough, but just stay curious, keep looking it up.
Education.
Yeah, and learn how to find the information quickly. We all don't know everything. It's impossible to know everything. So know those drug information resources and how to get the information quickly. And don't be afraid to say, I'm not sure, I need to look it up, or let me double check this for you. How can I get back to you? What's the time frame you need for me to get this information to you?
Yeah, it's better to be completely sure than
Yeah.
take some than to just give like half of an answer and then be unsure of yourself. Like you start second guessing yourself. So it's better to do your research and just be upfront about it, because like you said, none of us are expected to know everything. We're just given like the basic ground for knowledge so we can like jump up to the next level. But from there, it doesn't stop. Continuous education is basically the motto of our life,
Yeah.
especially if it's medicine we're talking about, because it's people's lives that we're dealing with. So we always got to be on top. There's like little to no room for error. So
Mhm.
that's
Yeah,
pretty good.
definitely. I did think about graphic design or
Oh, wow.
forensic scientist.
See, forensic scientist is pretty cool. I'm not gonna
Yeah.
lie.
I don't think it's definitely not the same as you see on television though, but they
Uh,
make it seem really cool on television.
yeah, they kind of hype it up a bit more, but it's kind of the same idea, maybe not as flashy, but it's the same basis. So it is pretty cool nonetheless. Like working with biopsies and trying to investigate and understand how it happened, what happened during the homicide, like connecting the clues makes you feel like a scientific detective. So that is pretty neat.
Right, yeah.